around those voting questions. So just again to remind the CTAF panel, I hope you are all still in the voting software package, that you have no issues. If you do, please chat with Azanta or Laura. And to guide us through this, again, you have your evidence summary tables. And remember that we have the clinical experts and the patient experts available, should we wish to call on them to give further perspective or to have a comment. And so I hope they are back too. I haven't checked specifically, but I'm assuming they are back too. So let's go ahead and show the first voting question so that we can start to frame the discussion. All right, and essentially for all of these questions, or maybe some similar preamble, this question says, given the currently available evidence, in patients who have dialysis independent CKD, is the evidence, or incident I should say, is the, wait, can we be clear about something? Sorry, DI, it is dialysis independent, forgive me. There's been incident dialysis and other terms thrown around, but this is dialysis independent. CKD, is the evidence adequate to demonstrate the net health benefit of roxadustat is superior to that provided by usual care? And here, usual care, as quite often the case, is estimated by the placebo arms in the trials that are available. So let me first ask Reem, if she would, to please very briefly summarize again the clinical trial evidence or other critical evidence that we have, referring to the tables, and to also briefly summarize the evidence rating and the rationale behind it. And I hope Reem is back.
I am.
There she is, good.
So this is about patient with the dialysis independent CKD. And this is the group in the evidence summary. If you look at table 3. So for table 3, dialysis independent CKD, and we rated the evidence for that as insufficient. The one statistically significant effect estimate was decreasing the risk of IV iron supplementation.
Okay, and our evidence rating was?
Insufficient.
Right, okay.
I just want to make sure, I'm a little concerned. The question is, table 3 is versus ESA, and I know that was the order we had presented things in, but that question seemed like it was versus,
yes, it's versus
placebo. So it may be that we're, am I wrong?
No, you're right. You're right, David. I was just going to go ahead. So which is it? Table, which table is it?
Then that's table 4. Apologies.
Got it.
And it's table 4, and the rating of the evidence remains insufficient.
And additionally, on that specific issue, just because this is the one where I had presented the mortality numbers and we got comment back, I just wanted to say that the Olympus trial, which we were told was published yesterday, completed in October of 2018 and published yesterday, and it had the 1.15 relative risk for mortality in the published document, the same as we showed you. So there wasn't any difference between what was published yesterday and what we showed you. And just because it was suggested that ICER's analysis was premature, you should know that the other 2 trials, ALPS completed in November of 2017, and Andes completed in September of 2018. And we have one of those published now.
David, sorry, just so I'm clear, the 1.15, the 1.06 that was the company's statement of the hazard ratio, the pooled hazard ratio, was that this population? And now you're saying the published data was 1.15?
Well, that the 1.15 is the way we had calculated it.
Right.
This single trial. The pooled hazard ratio of 1.06 is pooled. And we know that that included all the events out to the end of the trial, even when people were no longer on therapy. But just to know that as published, the number that shows up in the published document gives that same 1.15 if you look at the relative risk.
David, so just to be very clear, all of these numbers are suggesting that mortality is either significantly or a trend toward increase with Reduxistat. Is that correct?
Well, none of them individually were statistically significant among the 3 trials.
Got it.
When we
But the
pool
trend
them,
is toward.
when we pool them, it's right at the edge of statistical significance done that way. We would have liked to pool the hazard ratios, but that isn't the numbers that we have.
Great. The second question is about the Pyrenees trial. Is that a different population entirely?
Yeah, we'll get to that in the dialysis-dependent population.
Okay, thank you.
Okay, so the floor is open to questions.
I'll ask Reem about the quality of life measures. It seems like they're fairly small and not significant, but the negative, do they suggest a trend towards better, worse quality of life with Reduxistat?
Yeah, a great question. Thank you. So when we look again, table 4 in the summary about the quality of life measures, there are 3 different components, if you may. There is the physical function, vitality, and physical component. And when you look at the direction of the effect, it looks like there is direction in the improvement, but it is not, none of them reaches any clinical significance when we look at that.
All right, I know we've had a fair amount of discussion about this before the lunch break. Let me just invite either of the clinical experts, Dr. Kapitsinu or Dr. Burns. Either of you like to comment on this issue, on the issue of the data that, as you see it?
Yeah, I can start by, stating that definitely there are some wide confidence intervals in the analysis of this data. And obviously, it has to do with the number of the patients included. I mean, the numbers are, are not bad, but probably they are underpowered to detect, meaningful differences. So with the current, data, and although, I have to disclose, I'm not like an expert, in epidemiology, but my take-home message is that things are, uncertain, and it's, unclear to which direction exactly mortality, for example, is affected, which is the main, parameter to look at for this analysis.
Okay. Dr. Burns, if there's anything you'd like to add, please feel free to. Otherwise, I think we may be close to moving forward to a vote. Okay, Ralph, I'll go ahead and turn to Ralph for a question or a comment.
Yeah, I just have a general question for our experts. It seems like most of the trials had impressive exclusionary criteria. Patients with heart failure, I think recent MI, acute coronary syndrome, stroke, severe hypertension. These are the patients that have chronic kidney disease. And so I was wondering what, by excluding these high-risk patients, what data these clinical trials truly offer us as clinicians, and how might that affect, to the best of your knowledge, how we should view these trials and the results that we have.
Again, so I think that you raise an excellent, really excellent point here. And it's true, the CKD population, the ESRD population is particularly enriched, for severe cardiovascular disease. There is a very close connection, and these are actually, the diseases, cardiovascular disease that, drives mainly the mortality of these patients. Now, I have to state though that even with with ESAs, we know that when a patient has a recent stroke or myocardial infarction, we are holding the ESA treatment, and there are not very clear clinical guidelines for the duration, and a lot of times this is up to the judgment of the treating clinician to weigh the benefit risk ratio. So from this regard, given that these are flags even for ESA therapies, I would not really take this as a negative point for these initial trials, because also someone has to start to do a trial in a safe way. So I won't consider this a negative point at the current time, but in the future, when we are in the clinical practice, these are critical aspects that need to be defined, and we need more data to actually be able to decide how these patients, which is probably the majority, will be treated.
All right, thank you. I'll just note that Dr. Burns is trying to regain Zoom access, so hopefully we'll be able to hear from him again soon. Any other questions or comments? Thank you, Ralph, for that question. Okay, let's go back to the voting slide, please. And again, each time I'm going to try to not be mistaken, but you also make sure we're thinking about the right patient population, the right comparison. So dialysis independent, comparing roxadustat to placebo, usual care. Is the evidence adequate to demonstrate a net health benefit for roxadustat? Please go ahead and vote A for yes or B for no. Okay, thanks. We have everybody's vote. Okay, 15 no and 0 yes. All right. So let's go forward. Next question may seem somewhat, again, perplexing to be asked after that vote, but let's reflect on the evidence as it is for roxadustat versus ESAs in this patient population and consider another vote. Reem, again, can you please steer us to the right results on the table and recap the ICER team's evidence rating?
Sure. So that's going to now be table 3. And in table 3, as you see, there was no statistically significant difference for all-cause mortality, MACE or MACE plus, or any of the other cardiovascular events. There was also no statistical difference for quality of life. The outcome that had a statistically significant difference was decreasing the risk of IV iron supplementation in the roxadustat arm. And there were, in all of these, really discontinuation due to adverse event was higher in the treatment arm. And again, our rating for the evidence here, the certainty of the evidence was insufficient.
Okay, thanks. Any questions or comments from the CTAF panel? All right. I believe this is an area, again, where we did a pretty good job having the chance to discuss it earlier. All right, if I'm seeing nothing, let's go ahead and take the vote then, please. Okay, for still the dialysis independent population, we are now comparing, or saying, or asking, is the evidence adequate to distinguish the net health benefit between the two treatment options? Looked like I was behind you guys. 15-0 again. Okay, thank you. The third question, we can skip that one since the answer was not yes. Okay, shifting to the other population, dialysis dependent. Here the question is, given the available current evidence, is in patients who have dialysis dependent CKD, is the evidence adequate here to distinguish the net health benefit between roxadustat and ESAs? Reem?
This is now table 5. In table 5, we look at the dialysis dependent CKD group comparing roxadustat versus ESA. As you will see, for example, the all-cause mortality, where we had the discussion around including versus not including parentes in all these outcomes, and that when we include parentes, for example, the all-cause mortality was a relative risk of 1.05. When we don't include parentes and look at the hazard ratio reported to us in a pooled estimate, it was 0.96. And the one outcome that had a statistically significant difference, again, was risk of blood transfusion and decrease in the risk of needing IV iron use. And we did rate the certainty of the evidence insufficient. Here again, again pointing to a lot of the uncertainty around not only the wide confidence interval, but we had questions about some of the provided pooled estimate for two reasons. One, including versus not including parentes, and two, at what time point were these effect estimate pooled, 28 days versus longer, and so on.
Okay. Thank you. Reem, can I just get a comment on two other things that I'm sure the panel is going to be thinking about as well? So, of course, it's somewhat true in all these situations, but the risk of blood transfusion, as I'm looking at it, at least one of the footnoted results was at least statistically significant. And then the MACE plus, I know that composite, you discussed a little bit where MACE plus came from, and I just think it'd be helpful for you to summarize again the team's thinking about the MACE plus results and what you made of risk of blood transfusion as a clinical benefit in this context.
Right. So starting with the MACE plus, the difficulty we have with the reported MACE plus result here is, as you see with the two pluses, these results did not include parentes, similar to the MACE. So these pooled estimate don't include parentes. And when we look at parentes, which was a stable dialysis dependent group of patients, we worry that this would be an underestimation of the true effect. We don't have reasons, after talking with our patients and experts, to think that parentes is different and we should treat it differently. So that's why we're not putting a lot of emphasis on the statistically significant result for MACE plus. The other issue about blood transfusion is an important clinical outcome, and it does show statistically significant reduction in blood transfusion. However, one of the issues with these trials is patients on roxadustat were also allowed to receive ESAs. So as part of the protocol, they were allowed to receive ESAs, and it's kind of hard to distinguish if how much of the reduction of blood transfusion were only dependent because of the roxadustat and how much additional ESAs were used in these arms. I don't know if anyone else from ICER or the clinical expert would like to comment on this, but these are really important points to consider as you're looking through this.
Dr. Burns, I think we have you back. Would you like to respond in any way?
Yeah, I am back. Sorry.
No worries.
Just one comment that I wanted to make earlier, but I'll bring up here, relates to transfusion, and it's maybe partly a question, partly a comment, and that is whether when you look at transfusion rates, since that's one of the outcomes that may be different among in some of these trials and comparing roxadustat to an ESA, is the hemoglobin level that was achieved in those patients, because the need for transfusion is very hemoglobin dependent. In a study like these, to say that a hemoglobin was higher with roxadustat versus an ESA is really just a dosing issue. It's not clinically important really, but it is if you're looking at an outcome such as transfusion. So, a hemoglobin difference of 1 gram per deciliter will likely have, a significant difference, as will, if you look at the spectrum of patients or subjects in a clinical trial, if there's a higher percentage of subjects in the roxadustat arm, let's say, that have hemoglobins above 12, than in an ESA treated group, even if the mean hemoglobins are close to one another, that will also reduce potentially the transfusion requirement. But that's just a function of study design. And I think that that's something that would be worth taking a look at in trying to make sense of whether or not this transfusion difference is real or really just a function of achieved hemoglobins within the study.
So is it fair to paraphrase what you just said, that even if you, as you look at a finding on blood transfusion, different things could be going on in terms of the dosing behind the scenes and trying to figure out how much of a clinical benefit, quote unquote, that might be? Is that true?
Yeah, I think that's right. Particularly for the dialysis population, most of the transfusions are, at least in the United States, occur outside a dialysis unit and largely outside the control of the nephrologist taking care of the patient. I think we really don't know what's happening with transfusions in the non-dialysis CKD population yet. We do know, and this is now data that's 2 years old from the USRDS, the transfusion rates have actually gone down in the United States. I think somebody had mentioned that there was an increase among dialysis patients, but at least as of 2018 USRDS data, the number of transfusions and the number of patients who've been transfused and the number of transfusions overall has declined in the United States.
Okay. All right, thanks. I see a number of questions. Let's see if we can get through them. Let me start with Jeff.
Thank you. In looking at table 5, we were commenting on less transfusion, and that was a good thing. However, when I look at the bottom of table 5, I think I see a lot greater chance of discontinuation due to treatment emergent adverse events or adverse events. And I was wondering if the clinical experts could help me understand if you feel that's real and if that might decrease some of the benefits that people might be perceiving in the risk of blood transfusion being shrunk. Is the discontinuation something that would give me pause as well, or that's just a minor thing to worry about?
Can you share the table, or I'm not sure which table you're referring to?
Sure, I'll share the table. So I hope this is the right table. This is the part that I was looking at, and I heard a lot of our discussion talking about this, and I thought that's great. But if I were a patient person, I think I'd be worried about this.
Yeah, I mean, they're obviously both important, and it would depend on I guess what exactly falls into that treatment discontinuation. I think, and the point that you're making is actually an important one. I think in general, when we're thinking about these kinds of things, in that what's important to the patient. So adverse events are probably important to patients, particularly those that are severe or lead to discontinuation of a study. Transfusion is probably important to patients. Their hemoglobin level per se is probably not. And so, I think that needs to be taken into consideration when we think about some of these things. And even if you look at this table here, the mean monthly IV iron use in milligrams, may or may not be important to the patient. It depends on how much iron. What's really important to the patient is how many times they needed to get IV iron, particularly if they were not on dialysis. If they had to go into an infusion center and get stuck with a needle to get iron more times, that's more important to a patient than how much was given per infusion of iron, if that's making sense.
I would like to add a point to what Dr. Burns just added. I do not have access to this data, but we know that although it's not clear that maybe prolyl hydroxylase inhibitors induce hyperkalemia, and I'm wondering if Dr. Mustafa knows, or anyone familiar with the studies, what was the contribution of hyperkalemia in discontinuation here?
Yeah, thanks, Dr. Cappuccino. We did look at this data when it was available, and that is information that is available in the main report. It was limited with which trials reported specifically on that. And I'm just going to have to go back. It didn't strike me as something that I'm remembering off the top of my head, but it is reported in the full report. If you give me a second, we'll report that in the chat.
Okay, Joy, why don't you go ahead?
I think I had a similar question, but I was gonna also ask Dr. Mustafa, maybe not just about hyperkalemia, but about other adverse events and what that composite measure mainly includes, if you know, because that it does seem somewhat important. Honestly, I don't know that it's that important for voting on this particular question, but it seems important to patients generally.
Reem, I think we've created an appetite to have the answer to that question if you feel like you guys have the time to find it. If not, we can go ahead and vote, but it sounds like it'd be nice if somebody can find it.
I don't know if Grace can find it faster than I can do. I'm just looking. If you give me a second, we should be able to get you the answer.
Well, while we're waiting for Reem to do that, I'll just comment again on the Pyrenees inclusion or exclusion. So we have these 4 trials. If you imagine that Pyrenees is somehow different from the others, that would suggest that in stable dialysis patients, if you used ESAs the way in Pyrenees it was done, because that was such a great way to do it, that you can reduce mortality compared with roxadustat by 35%, which would be huge. I actually don't think that's right. I think we should be pooling these numbers together, and then you get the numbers that we gave you. But picking out the one trial in which ESAs dramatically outperformed roxadustat so that you don't have to pool it in would suggest that you should be doing that rather than using roxadustat in those patients. Again, I think the correct thing to do is to pool the 4 trials together. There's no reason not to.
Thanks, David. And you can see now in the chat, I'll read it for those. I don't think everybody can see it, but who's attending. It says in the DD-CTK population, the most commonly reported treatment-associated adverse effects were nausea, diarrhea, hyperkalemia, and hypertension. Percents for each of those are not shown.
Thank you. David, I mean, I think the one question or comment I guess I have is it almost feels like the Pyrenees population of prevalent dialysis-dependent patients is actually the patient population that will be the largest component of the people that are being used. And so you could, it feels like, make an intellectual argument of, even if it is separate, we should actually be paying more attention to the Pyrenees numbers as opposed to the other numbers, because honestly, how, somebody is incident only once, but somebody is in the prevalent cohort for the entire time that they are on dialysis.
Yeah, we had asked for, from each of the trials, except the one that didn't have prevalent dialysis patients, the subgroup that was prevalent, because we did want to pool those, since the argument was being made that it worked better in the incident patients. That would suggest that in the prevalent patients, it's probably worse than the average, but we don't have those numbers to be sure. And again, I think it's dangerous to post hoc look at the data and pick out which trials you want to pool. I'm more comfortable pooling it all together at the moment.
And maybe just from a practical point of view, again, given that these are oral medications, you would suspect that as patients are in the dialysis independent, they would really prefer an oral option. And as they transition into dialysis dependent, in the beginning, they may continue with the medications they're using until there is a change. So I think from the practical point of view, you can view that group as actually maybe being on a regimen that is similar to their pre-dialysis regimen. But we don't really know that. These are all speculations.
Maybe I can make a comment in response. There's even in the not on dialysis CKD population, I sort of think of them as two very large buckets. There's a group that has Medicare, and those individuals are required to get their ESA administered at a healthcare facility for the most part. Whereas those not on Medicare can generally get it, can self-administer. Although insurance coverage certainly varies, but if you look at, for instance, darbepoetin, patients may inject once or twice a month at home. Honestly, I don't know whether some would prefer to do that rather than taking yet another pill 3 times a week, as many of these patients already have a pretty large pill burden. Certainly those that have Medicare and have to come into a healthcare facility, then that, calculus is a little bit different because they would not now have to come into a healthcare facility to get their injection. But again, that would be an individual decision that each patient would end up having to make.
Thanks, and we're going to come back very much to those issues around patient preference and the payment bundling, et cetera, when we hit the policy roundtable for sure. I'm not seeing any further questions from the CTAF, so let's go ahead and go back to the voting slide and throw it up again. So please take your votes on the dialysis-dependent population. Is the evidence adequate to distinguish the net health benefit between roxadustat and the ESAs? Okay. All right, we seem to have a theme going with these votes. Thank you. I believe, so we can skip question 3A, and that sends us right into the next, don't worry, okay, good. I was gonna say, don't try to even think about that slide because we're not gonna be voting on that slide, but that was just to show the public, in a sense, the structure of the next series of questions. These are going to be questions that evaluate what we call potential other benefits or contextual considerations. You'll remember from my introduction the role that these can play in thinking about value from a broader context in relationship to the cost effectiveness. So we'll run through each of these, and then the panel will be discussing them briefly because we have a series of about 7 or 8 of these questions. And each vote will be on a voting structure of 1, 2, or 3. 1 in general will suggest slightly lower value, or more, I shouldn't say slightly, will suggest lower value to some extent. 2 is kind of neutral or average in some sense. And 3 would be a result that would suggest a higher value within whatever kind of structure or framework around thinking about a fair price or a cost effectiveness range that you're thinking about. So this first one is about uncertainty. And we're talking about the DI, the dialysis independent population. Number 1, uncertainty or favorable model assumptions creates the risk that the base case modeling estimates that you saw were too optimistic. 3 would be that the uncertainty or the unfavorable model assumptions create significant risk that the base case was too pessimistic. Now, we're kind of in a strange situation here because we do have a base case, and I'll ask Lisa to quickly reflect upon it. But I think you will remember she did a great job of showing the different degrees of uncertainty. So this isn't, in a sense, about whether there is a lot of uncertainty or not. It's whether you think that the assumptions and the way the model is structured, in a sense, are in general too favorable or too pessimistic. So Lisa, do you want to go ahead and just, or Josh, whoever's going to do it very briefly, describe the findings?
Sure. So for these, I'll refer you to Table 6. It gives the results of in the dialysis independent population. And just as a refresher, we found some cost savings in this population, primarily driven by the assumed placeholder price of the drug, but there were some other cost savings with reduced use of IV iron, with no real difference in QALYs or life years.
Right, and here partly because we don't have a price, in a sense, the QALYs are almost the more germane issue to whether they feel it's overly, other aspects of the cost as well, I suppose, that could be overly favorable or unfavorable. But we're not asking you to guess whether the placeholder price itself was too optimistic or too pessimistic. All right, does anybody have any questions about this before we vote? Okay, Jeff?
I wondered, when you were making assumptions, because we have to do that when we make models, do you feel like you tended to err on the side of assumptions that would make the new drug look good, or did you tend to err on the side of assumptions that would make the new drug look bad?
Well, of course, we tried to be balanced and driven by the data. So I think we would have to talk about, I guess, different sort of assumptions. So for mortality or MACE plus, this is versus ESAs. So we did not use the point estimate for mortality or MACE plus events from the head-to-head trial, although it was the point estimate did show reduced hazard ratio for mortality for that. We included that as a sensitivity analysis. So that's one instance where we could, our point estimate or our decision not to include that in the base case could have been overly pessimistic. In other places, we may have been overly optimistic, like the assumed placeholder price, which was a little bit less than the price of ESAs that we assumed. So it kind of depends. It can go either way.
Thank you.
Good. Any other questions from the CTAF? Okay, let's go back to that question, please. Okay, please vote 1, 2, or 3 on your opinion about the uncertainty and whether it tilts the model results in general towards overly favorable or overly unfavorable. Okay, we can see the results, please. Okay, 2 said overly favorable and 13 were in the middle. Great, let's go to the next question. Same question, just for the different modeling, I guess, of the dialysis dependent population. Lisa, is there anything about the assumptions that went into that you would highlight as being different in some sense from the DI population?
Well, the biggest single difference between the DI population is that for the dialysis dependent population, we did include all of the MACE plus events individually. So we did have a difference in the hazard of mortality. The point estimate was slightly above 1, but with a wide credible interval. And then we also included all the individual MACE plus events. Otherwise, our choice of what to include in our assumptions were pretty much the same and driven by what was seen in the trials.
Okay. Any questions? All right, let's go ahead and go back and vote, since a lot of the model is obviously based in the same way. All right, please vote 1, 2, or 3. 1 is again, the assumptions would suggest lower value because they're overly favorable. And the other side, okay, we've already got 15 votes. Okay, very similar to the previous voting. Thank you. All right, so here we're getting to different elements again of what we might call a potential other benefit. So number 1 here is that this treatment, roxadustat, represents a very similar mechanism of action to that of other active treatments. Number 3 is that it's a new mechanism of action compared to that of other active treatments. The reason there's a 2 is partly because sometimes, mechanisms of action are kind of similar to something before, and sometimes they're completely new. So Reem, do you want to just remind them, I think they remember, but just briefly remind them of this mechanism of action and its relationship to previous treatments?
Sure. This is a pretty novel mechanism of action that actually inherently increases the internal production of erythropoietin in different organisms, specifically mostly the kidney and liver. So even if patients don't have kidneys and their kidneys are removed, it will still help that increase internal production. And the idea is that we do see levels that are not as very high and then very low. It's lower level, but they are consistent. And it's mentioned already, this actually was the reason for one of the Nobel prizes. So it's a pretty important mechanism for new action.
Okay, I think that as information as it goes is pretty clear. Not seeing any hands, which makes some sense. Let's go back to the voting question, please, and complete your voting. Very similar as number 1, new is number 3. Okay. All right, 14 threes and 1 2. Thank you. Let's go to the next one. Okay, let me just read this again. On the lower value side, it says the delivery mechanism or the relative complexity of the regimen is likely to lead to much lower real-world adherence and worse outcomes thereby relative to an active comparator than estimated from clinical trials. Number 3, on the flip side, is that there's something about the delivery mechanism or the relative simplicity of the regimen that's likely to result in a higher real-world adherence and better outcomes relative to an active comparator than estimated from clinical trials. Given that the real world is different than clinical trials, here we're dealing with the question of an oral treatment. I'd like you to focus on the dialysis independent population. We're going to dive deep into the weeds on both in the policy roundtable. But in terms of thinking about whether decision makers should consider this is a particularly interesting or important part of value, let's talk about this. And I'd love to hear actually from either Patrick or Troy, your feeling from the patient perspective. What do you think about the fact that this is an oral treatment? You heard a little bit about pill burden, but do you think this is going to be viewed as something that would significantly increase the likelihood of adherence compared to ESAs in the dialysis independent population or not? Can we go back to the general view? Troy or Patrick, do you have a thought on that?
Yeah, this is Patrick. Yeah, medication burden does play a lot in consideration for adherence, but I believe if it's in pill form, it'll probably be less likely for folks to actually take the medication. Because with the amount of medications that dialysis patients and transplant patients take, it can be burdensome sometimes.
Okay, I mean, the comparison here is the ESAs, which, as you know, are an injection. So
Right.
just so you're clear, that's kind of the question here is between those two.
Okay, well, nobody likes to get an injection. I know at least with dialysis patients, they can add that during dialysis, but
Right.
if it's necessary to help manage anemia, then folks will do what they need to do overall.
Okay, thanks. Would either of the clinical experts like to offer a thought on this as well from your clinical experience? Do you have a feeling this will make a strong difference in the adherence at home?
Happy to comment, but Troy also, I think, wanted to comment.
Oh, he did. I
Yeah.
couldn't see him jump in. Troy, thank you. Go ahead.
You're welcome. I'm not a patient, represent the patients, of course. I would have thought the opposite of what Patrick said. So I certainly would defer to him. I did hear earlier in this conversation the comment, I don't recall who made it just a few minutes ago about, juggling a vast number of pills. I think it might have been Dr. Burns on a daily basis or a weekly basis. So I certainly understand that. But my assumption through all this discussion today would be that a patient would prefer not to require another injection.
Okay. Why don't we just go with that then? I think we've heard this, and we did have, thank you, Dr. Burns and Dr. Kapetsin, we heard a little bit about that previously. So, and with apologies, Elizabeth and Joy, I'm just a little bit tight for time. So I think I'm going to go back to the voting question and let people go ahead and vote on this one. So when you vote, please, 1 would suggest lower value because the delivery mechanism or the complexity makes it somewhat likely, at least, that there would be lower real-world adherence. Number 3 would suggest higher value for the delivery mechanism or simplicity being likely to result in higher adherence. Okay, thank you for voting quickly. Okay, we've got 6 neutrals. Maybe we heard a balance there, and then 9 and number 3 suggesting higher value for the oral option. Okay, excellent. All right, something that we want to think about also is whether a treatment has a differential impact on the historically disadvantaged community. So here, again, you're going to need to think a little bit, in this case, about whether you believe the treatment does work, because if it didn't work, then it really wouldn't have much benefit for a historically disadvantaged or other community. So number 1 here is this intervention will not differentially benefit a historically disadvantaged community. Number 3 is that it would. So we should probably start again with just a reflection on the prevalent, if you will, population of patients with CKD and whether they reflect a historically disadvantaged community. Reem, I know you gave the information at the beginning, but do you mind briefly summarizing again?
Sure. So historically disadvantaged population and racially diverse population are more common to have chronic kidney disease, and unfortunately, they're less likely to receive treatment or receive same level of hemoglobin as other populations. Yeah, that's it.
Okay. I see Rena.
Just want to make sure does this question require that we assume there is a benefit?
It asks you to actually, this is one of the questions where you're supposed to think about the benefit, the relative benefit. So there are 2 questions coming in a row where you won't, but in this one, I would like you to think, to the extent that you feel that this would add a benefit to patients, will it differentially benefit a historically disadvantaged community? That would mean that even if you do feel this is a historically disadvantaged community, or proportion or predominantly one, that if you do not think that this would add net health benefit, then you would not think that it does much to help us address disparities or to treat that issue. Okay, thank you for asking that, because I know that is a tricky part of this question. All right, let's go ahead and go back and vote. All right, thank you. Number 1 is it will not differentially benefit a historically disadvantaged community. Number 3 is that it will. 2 is neutral. All right. Okay, we have our first kind of split decision, if you will, but we've got 4 number 3s, 6 number 2s, and 5 number 1s. Just to make sure we have time to discuss the rest of these areas, I'm not going to do a deep debrief on this, but I know that it did involve different elements of whether the drug is viewed as giving a net health benefit, as well as whether it is a historically disadvantaged community, which I think most people would agree that it is. Okay, now we're going to be talking, now the CTAF panel is familiar with these questions. Most of the viewing public will not be, but this is related to ways to try to capture the severity or burden of illness to a certain extent through different kind of lenses. The first one is talking about the health loss as it relates to the absolute quality adjusted life year shortfall. And that is generally meant to imply a kind of a longer, if you will, lifetime even burden of illness. And it does not matter whether the treatment is effective or not. It just matters whether this condition represents a condition that causes, if you will, a significant health loss on an absolute basis. So number 1 would be something that is low on the quality adjusted shortfall, quality shortfall scale. 3 would be something that's high in that regard. And I can go ahead and point you to the table in the evidence summary. It is the last table in that document, table 10, if I'm not mistaken. And just to read again a couple of the others, because you guys can see it, but the absolute shortfalls for both DI and DD elements of the population are around 20 years, 20 QALYs. And that is close to secondary progressive multiple sclerosis and a couple other conditions at that range. So I know you guys can see this. You're familiar with this way of thinking about the quality shortfall. Does anybody have any questions about this before we vote? All right, let's go back to the voting question then. So the question again is, with 1 being suggesting lower value and 3 higher value, 2 being neutral, how would you consider the health loss for patients with this condition on the basis of the absolute quality shortfall? Okay, thank you. All right, we've got 10 3s and 5 2s. All right, the next question is similar but different. How's that? Similar in that it's asking about health loss. Different in that it's asking about the proportional quality, which again captures a loss that is sensitive to the amount of time left often that patients have in their lifespan. And so that a relatively high proportion of that lifespan, the quality and the length of that life that might be lost to a condition can be viewed differently than a longer, if you will, a condition that strikes over many decades. So the findings here again from table 10 show a proportional shortfall of around between 0.75 and 0.8. And that's again relatively close to secondary progressive multiple sclerosis. It's higher though than many of the other findings on this, including cystic fibrosis, hemophilia A, and treatment-resistant major depression. So let's go back again and let people see each other. Does anybody have any questions about this vote on a different way to think about health loss? Excellent. Okay, thank you. You guys, let's go back to the vote. 1 would suggest lower value, 2 is neutral, 3 is higher value on the basis of the proportional quality shortfall. All right, and the results, okay, fairly similar, 6 2s and 9 3s. All right, almost done. We have 2 more of these before we will be able to take a very brief break, I think, or maybe we'll just move right to the policy roundtable. So this one is about caregivers, all right? So here, number 1 would be this treatment, and here again, you have to think about its effectiveness, not just the condition full stop, but does this treatment do something? Will it or will it not significantly reduce the negative impact of this condition on family and caregivers versus the comparator? And in this regard, we want you to think of ESAs as the comparator. All right. So, and it's usually meant to imply that the treatment will have beneficial effects on the patient that will spill over to affect the lives of caregivers. Sometimes that can be a very major kind of component of the effect of a treatment, sometimes less so. The issue here is whether you think it's a 1, which would be it really won't have much of an effect at all. Number 2 would be neutral, and 3 it would significantly reduce the negative impact of this condition on caregivers. If we go back to the screen where we can see each other again, I know this is kind of an odd way to think about it, but again, I'd invite the patients or clinical experts, if you see any particular aspects of this treatment of roxadustat that you think would particularly benefit caregivers that you don't think is evident from what we've already talked about, please feel free to talk about it. Okay, that's all right. I mean, these are opportunities for us to make sure that we're capturing broader aspects of value, and sometimes they're more relevant than other times. And I know you guys have thought about this a fair amount. So let's go back to the voting question. Okay, so for roxadustat versus the ESAs, number 1 is will not significantly reduce the negative impact of the condition on family and caregivers, and number 3 is that it will significantly reduce the negative impact on caregivers. Okay, the results are 2 1s, 7 2s, and 6 3s. Thank you. All right, 1 more, and this is about the patient, him or herself. Number 1 is this treatment as it is, as effective as it is or isn't, will it have a significant impact on improving the return to work and or the overall productivity versus the comparators of ESAs? Number one is obviously it will not. Number three is it will have a significant impact. And again, this requires you to think about your judgment of how much of a clinical effect it has and how that might spill over, in this case, into patients' ability to return to work and have more effectiveness in all of their daily roles. Go back to the screen view of everybody. Would any of the patient representatives like to say anything on that one, or you feel like we've covered it adequately? Okay, I'm sensing a desire to move forward. Let's do so. We'll go back to the vote. Okay, and again, we had somewhat of a split. We had 3 number 1s, 8 neutrals, and 4 number 3s. I think these are challenging questions, partly because it doesn't require a combination of 2 judgments, and that's often a difficult thing to try to capture in a single number. But I think it's helpful for us to think broadly about these effects as well. Okay, we can now move forward, and I was right in my, oh, that's right, we're gonna just skip this one so we can keep going into the policy roundtable. Okay, everybody else take a deep breath except for me, okay, for a second, because we're not gonna kind of take 5 minutes, and usually we have some break here, but because of the way we structured this agenda, we're gonna just move right into it. And we're just a few